It is Chicago, and we are here at the 2016 ASH meeting on hematologic malignancies. Now, the majority of the program content is structured with world-class experts discussing how I treat various hematologic malignancies. And we are here right now to review how I treat high-grade myelodysplastic syndromes. And to do that, I'm with Dr. Hetty Caraway, who is an associate professor of medicine and the director of the Hematology Oncology Fellowship Program at the Taussig Cancer Institute at the Cleveland Clinic. Now, you started out and you reviewed the 2016 WHO classification update to the diagnosis of high-grade lymphomas. Can we start there?
Sure, and that would be high-grade myelodysplastic syndromes that I reviewed. The 2016 WHO now includes some really relevant changes to the diagnosis of patients with MDS, specifically eliminating refractory anemia as some of the definition and really changing it to purely MDS. Other things that I think are most exciting about the classification is really now we're starting to include molecular data to actually help us classify these and identify these diagnoses. And so for the first time, we're actually incorporating those tools, which is a big step.
So you know exactly what you're dealing with.
Yeah, and it's a very exciting time to have that as included in the classification system, just because some of these mutations will also select for potential targeted therapy, and so that will be pretty exciting in years to come.
And you spent some time on the International Prognostic Scoring System for patients diagnosed with high-grade myelodysplastic syndromes.
I did.
What's new there?
Again, one of the things that's just really exciting in MDS is at some point we will be incorporating this genomic information into the scoring system for patients. We're not quite there yet. We wait for data to come out in the next number of years using molecular data to help stratify patients. But that in and of itself, at the first start of giving prognosis to patients and directing therapy, we really have to go back to the basics and use the International Prognostic Scoring System as well as the revised International Prognostic Scoring System and remind all clinicians that they need to use these tools to inform patients about their prognosis and what kind of therapies would be most appropriate for them.
Well, let's talk about treatment options, having gotten some of the basic stuff out of the way. What did you discuss?
We really focused on using hypomethylating therapy in patients that are diagnosed with high-risk MDS. And the reason why we discussed this is because those agents are the FDA-approved agents for patients with high-grade MDS. And it's really important to use those optimally and accurately so that patients are receiving accurate therapy because after they fail these therapies, their prognosis is pretty dismal. And so it's really important to make sure that we're treating them as best we can up front and get the best therapy and outcomes for them as soon as we can.
Things have changed pretty much in the last couple of years particularly, right? So if you haven't changed kind of the way you're managing patients, you really must.
I would say so. I think it's important to make sure that these patients get accurate therapy and stay on therapy, specifically if they're actually benefiting from it. Certainly for those patients that are failing therapy, obviously we don't want to give them toxicity with no benefit, and they then of course will come off study. For those patients that are appropriate, we then move them to a bone marrow transplant option, and the options for bone marrow transplant at this point are also very different than they were in years past, just because of the innovations and improvements in reduced intensity conditioning. So all of those things are really important for us to remind people of. I think we have options that we didn't in years past, and it's important for patients to be informed about them as well as physicians.
So what are the expected clinical outcomes and adverse events of these therapies that we're talking about?
For hypomethylating therapy, the adverse outcomes for patients really are continued cytopenias in the first couple of cycles. Any of our patients with high-risk MDS are at risk for infections and for needing transfusions, including both red blood cell and platelet transfusions. So they still continue to have those requirements and potentially be at risk for shortness of breath and fatigue because of anemia or even bleeding risks because of their platelets being low. I think the hardest thing for them is really infection risk and managing that, as well as some of the side effects from those agents, including nausea and diarrhea and fatigue, which can play into the quality of life for patients. But I think we do a pretty good job of managing those side effects. And we do know that even older patients over the age of 75 can tolerate these therapies and actually have shown in subset analyses improvement in overall survival by using them.
But the expected outcomes are pretty good, and better than they were in the past, correct?
I think we're able to deliver these agents better, and because of that, patients stay on therapy, and I think then they benefit from them. We're having better responses as a result.
In terms of, you just came from lunch where you had a chance to sit and people came over and ask a bunch of questions. What were the topics that people were asking about? What are the issues?
You know, for any of us, we want to know what to do when hypomethylating failure therapy doesn't work, or we want to know about the rare case where patients either doing super well and do you just keep them on that therapy and spare them the toxicity of transplant. They're realistic questions about what do you do for a patient and how do you maximize the benefit and minimize toxicities. And then some of the questions really revolve around what do we do in the post-HMA failure setting and what are the agents that are coming out. And Dr. Tallman spoke to some of the agents this morning in the acute myeloid leukemia setting that will likely be moved to this same population. So there was a lot to talk about today, the things that were relevant to high-grade MDS, but also to patients that transform and progress to acute myeloid leukemia.
So for the patient who is doing well, what do you do?
Yeah, it's a tricky question. And I think one of the things that I focused on was really looking at the patient and saying, what are your goals? What are your long-term goals? And you have to make those decisions together with your patient. But you know, obviously my goal is to try to cure as many patients as we can with the least amount of toxicity. But our goals need to really match the patients. So
this has to be an exciting time to be in your field of expertise.
Yeah, I have to say that I guess I'm a little bit biased, but I really love what I do, and I feel very fortunate to be at a time that we're learning about the genomics and mutations of patients with these myeloid malignancies, and I'm excited about what the future has to hold.
Yeah, the next few years could be really fun.
Yeah.
For ASH Clinical News, please take a look in the magazine and as well as online for more from this particular meeting. And for American Medical Communications, I'm Executive Editor Rick McGuire.